Let's talk about Kenya's healthcare sector. So we have all the governors in place apart from those two from Mombasa and Kakamega. But the others are in place. Health is devolved. So what do we expect to see? But before we welcome our esteemed guests, let's hear the day's proverb.
The soup will be none the worse for more meat.
Nah.
This is a proverb from Sudan.
In English? Not those.
If you have soup and you have other ingredients, if you add meat to it, even if there was meat, so now you have more meat, the soup will actually be better, not worse.
Soup is none the wiser.
None the worse.
Worse,
See,
no.
getting used to these bougie phrases.
The soup is none the wiser.
Things like, by and large, none the worse.
All right, nonetheless. Okay.
Soup would be none the worse. Hey. So at 7 o'clock we had Honorable Anthony Mweshige. At 8 o'clock we had His Excellency Okaniwa Ken. At 9 o'clock we have Her Majesty
Queen.
Dr. Mercy KORIR. Just going as we maliza the week.
And people just keep getting senior,
Honorable.
senior, and even more senior.
Excellency.
Thank you very much.
Her Majesty Dr. Mercy KORIR is our guest for this hour. She is, of course, a health journalist and editor for health and science at the Standard Group. Dr. KORIR,
Yes.
how are you?
I'm very well, thank you.
It's like you're seeing an apparition.
Hiya.
I'm back.
She's real.
Yeah,
Yeah. You've
Established.
confirmed.
Yeah.
you've established.
I'm back. I'm back.
You're well.
I'm good. I'm good.
Uh-huh.
When I heard CT talking about the soup
The none the wiser.
and none the worse, so he said if more seafood is added into the soup, it would be nice. That will stop being soup.
It will become the sea.
It will become a meal. No, cannot the sea. It will be a whole other meal.
Have you seen fisherman soup in Nigeria? You have to look for the liquid. Traffic jam in the plate.
So that is what CT is looking for.
Dr. Mercy, you're actually right. Because our idea of soup is some water substance with a little salt and a little coloring and nothing solid in it.
Yes.
Now,
Yeah.
we're saying now, add a little turbo to the soup, shall we? And visible ingredients, okay? Not virtual. Visible, so that you can see this resembles this and the other, this one resembles this and the other. And when you have more of it, then there's less doubt. And you actually know that this soup, the main ingredient is if you ever visit Tanzania and you ask for soup, it's what you say, it's a meal. Yes.
This fisherman soup she's talking about.
Yes, if you ask for beef soup, whatever you call it, there'll be a huge chunk of meat on a bone,
Yes, no.
with soup accompanying it, and that is soup. So you ask yourself, okay, so this is soup. Now, if I ask for
A meal.
yes, what exactly will they bring? Because this is clearly a meal, but it is soup.
Sawa. By and large, uko sawa.
By and large.
I am none the worse. With all that explanation.
And you could nevertheless.
You're none the wiser.
I'm none the worse. Nonetheless, we shall continue with the conversation today. Dr. Mercy, so governors are now in office. We definitely know we're going to have two new governors in Mombasa and Kakamega.
Definitely.
So we have new governors, other governors who have taken over office, others who have come back after what was initially considered misperformance in the first term. And then they were kicked out, and then they were like, hey, let's go back to Egypt. So the people of Laikipia and Baringo and other counties have gone back to Egypt and gone to their former governors. Health is a big issue. Health is a campaign issue for governors. Health is one of the metrics that is used to actually measure the performance of a governor. What should we be expecting? What are you hearing from the ground?
I think there are two key issues in regards to how the next regimes should handle health. And this is from both a national government perspective to the county governments. And the two issues are, one, on health financing, two, on human resource for health. Now, the health financing conversation is probably a much bigger one. When the ambassador for Japan was here, I think he was very polite, but what I got was that Kenya has been listed in CRB. So, but being a diplomat, he didn't say it like that. But like, you can't borrow. So, but you have all of these things. You're laughing, but isn't that the truth?
That's a nice way of putting it.
Okay, so
But Kenya is in CRB. So basically, you're not credit worthy. So we have to rethink.
but Mercy, in all honesty, credit rating doesn't mean you're not credit worthy. It just means that your credit worthiness has
some points.
limitations. Yes, because
Sasa ukienda CRB si kusema ati hawezi borrow tena.
or you can't actually.
Ni vile tu yani sasa.
CRB you can't borrow.
You can't borrow.
You can't.
But you see that
You can borrow, it depends from who.
People who don't subscribe to CRB, definitely.
Yes.
Like you
Okay,
can
yeah.
borrow from
Okay,
me
yeah.
because we are not CRB. Okay,
Yeah.
but bank, financial institution. Sorry, see the credit ratings. Even as we talk about it, they're an interesting thing and an interesting tool. Okay, because it's like whether they determine you the flavor of the month or not. On the one hand, if you borrow and you have issues with paying, it's an issue. On the other hand, when you actually borrow a great deal and you pay, then it's like you're saying you are able to borrow. So people keep lending you more. And the lending, oddly enough, has to do with your track record for borrowing. Because in the absence of your ability to borrow, you can't be credit rated. Yes.
borrow and repay.
Yes. A bit of a conundrum, isn't it?
Sure, unasema.
You know, I think there's a unit that people are taught in medical school on financial management.
Tumeenda CRB ama hatuko kwa CRB?
Sisi, hatuko CRB.
Now why can't we borrow from Japan?
So we can't borrow.
No, we can't borrow more. We've already borrowed.
Yeah, why can't we borrow more from Japan?
I'm explaining that the limit has been
You've
reached.
your limit.
What happens when you're listed on CRB? Can you borrow more?
You can't. You can't borrow at all.
Can we?
from
No,
other-
you have already borrowed. That's why you're on CRB, because you're not repaying. Can you borrow more?
No.
Okay. We have already borrowed. Can we borrow more?
What you said, and from people who don't subscribe to CRB, people who will not have
Will
a
not
chance
look at
of,
those
of
requirements.
checking, which means it's more dangerous.
Anyway, so
Anyway.
go back to your point.
So that was just talking about that. One, we need to finance all of these things that we need to do, and two is the human resource for health, which requires a substantial amount of money. Now, where do I pick these two things are key? Health is a service industry. You can have all fancy equipment, all fancy building, but if you do not have the doctors, the nurses, the clinical officers, their assistants, and everyone else who works there, then you just have a shell. And of late, we've been having quite a number of medics graduating from university, from KMTCs, tamarking and looking for work. Yet, on the other hand, we as Kenyans are looking for healthcare services where we are struggling to get somebody who can attend to you, or you need to wait longer, or you need to be referred to another town, and that comes with other attendant costs to it. So when you look at it, we need, for this industry to be able to work, you need to resource it with a human resource. But then now the bigger conversation is on financing, because all of these things need money.
Yeah.
The consumables that you use at the health sector, at the health, providing different health services will need money. So for me, the next governments, the 47+1, need to rethink how do we finance this health sector, because clearly, if the population is healthy, they are more productive. So these are not things that are tangible.
Yes.
you'll not be able to see that people are accessing health services, so there's this X return. You'll not be able to see it immediately, but in another 10, 15 years, you'll probably be able to do that. So there needs to be a lot of rethinking on how do we finance and how do we make sure that we have the human resource that is needed to get these wheels rolling.
Can we whittle it down a little bit? Because some of the issues that were faced 5 years ago are still being faced today. And we talk about the transition government as though it's some grand event that is going to take place, and it's going to be clear that there will be a difference between today and tomorrow. But the truth of the matter is that somebody who went, and this is a true example, somebody who went to KNH Level 6 Hospital, right, in Nairobi in July, and was trying to get a head CT, right?
Please, CT scan.
Scan. Okay, sorry. Since we're talking medical terms, I just kind of assumed that you would know. Sorry. Head CT scan, right, has been told that the earliest they can do that is in October this year, right? And you need the results of this scan to then be able to be told what further medical interventions then will be taken. So essentially what we are saying is, and this is with NHIF being able to pay for your bill, right? You will not be treated until you get that scan, because you don't know now what will happen thereafter, and you don't have the money to go to a private outfit to have this done. So this is what I'm saying. Transition government comes into place, but there's still existing issues that need to be handled. So if we whittle this down, Dr. how do we see this actually playing out? Because the issues are still heavy, they're still there, and they're numerous.
I think first of all is to appreciate that we have come a long way. We have improved. From the time when I was working in the public health sector, which was almost 10 years now, to now, there's been great improvement. I mean, there was a time that CT scan was not even available that easily. There was a time NHIF was not paying for that CT scan. So we've made some significant strides. So it's for us now to build on what we've been able to do and go to the next level. And how I say it is health being a devolved function gives us an opportunity to make sure that these services are devolved. For example, something like a CT scan, you shouldn't have to come and say queue in the level 6 referral hospitals to get a scan.
Sure.
Your level 4 hospital should be able to provide that. And level 4 is at the level of county governments.
Yes.
So why shouldn't we have all our level 4 facilities providing this? We have more than 5,000 health facilities across the country. Why should people come and queue and wait for days, for months, even to get a surgery in a level 6 facility?
But why are they? I'm sorry, I think, why are they queuing?
So which is what I'm saying, because these services are, one, either not available at a place you can easily access, or when they are available, the usual story, we do not have this kind of a specialist. Take a CT scan, for example. What I was saying, you may have a CT scan in a room, but if you do not have the radiographers, if you do not have the technicians, the radiologists, not so much, because nowadays with telemedicine, you can do that scan, send it to somebody, they give you a report.
Yes.
But you need the technical people to operate that. You need the biomedical engineers to make sure that this thing is always working. So it's not enough to just put it there. You have to go the extra mile and make sure that we are resourced, human resource, and other products and commodities that need to go with that scan, that need to make that scan function. And if the 47 counties were to look at it like that, that you want to make sure that I can just walk to the health center near to me and get my child vaccinated. I do not have to go to the county referral hospital, for example, to get vaccinated. So for me, it's about decentralizing and actually devolving the health services to people's locality so that they have ease of access within where they are. And so for me, this is should be a bigger conversation with more close coordination and collaboration between the national government, the Ministry of Health, that is, and the county governments, so that, for example, if you take the MES, for example, you do not have a situation where the national government decides this is what we are going to give you, take it, and it's a conditional grant.
Yes.
There has to be a collaboration and coordination. For example, and I was having this conversation the other day with somebody, would you have the same solution for Samburu, Turkana that you have for Nairobi? Possibly not, because where you have pastoralist communities, people are moving from one place to the other. You probably need to rethink how you're going to offer the services there. It would probably make more sense to have mobile clinics, to have maybe camel clinics, whatever that serves the people or what people understand there. In Nairobi, for example, you have more than, I think now we are at more than 100 health facilities, if you include the ones for NMS. Why are people still going to the level 6 facilities and the private health facilities? Here in, I think, where we are, Mombasa Road, we have a South B Health Center. We have one here in South C Health Center. Very well painted, very nice. But how many people access services there? Can you walk in there and say, I want to get my child vaccinated, for example? Or I have this wound that needs to be dressed?
You probably wouldn't, because they would not have some of those, what do you call them, consumables
Yes.
in the health facilities. And which brings the issue is, it sounds to me like everybody understands what needs to be done, you know, in some level. They may not be aligned in exactly what needs to be done in terms of priority number 1A1, but they all understand priority number 1. But the issue then comes into funding, which is the first issue that you're talking about, how to finance the health sector. Competing interests for the same amount of money, and then prioritization of the little amount of money that you have versus the urgency to provide the services. How do you balance those? If you are governor, if today you are the one who took over as governor, not of Nairobi, because there are so many new health facilities, say you've taken over as governor of Samburu County.
So this country, its health infrastructure was well laid out, well laid out from a long time ago, where you have actual health facilities that exist in almost every part of this country. That's why we have more than 5,000 of health facilities across the country. But you find that every government that comes in, or every county government, every MP, somebody wants to build another health facility so that you show, I'm the one who put up this building for you. So I think where I would start is make sure those that are already there, can they be up and running? Can they be up and running so that you're not focusing on brick and mortar? Because the brick and mortar is already there.
8 billion shilling, 600 bed, level 6 that will never finish.
That will never finish. Yeah, will never finish. And then, as I said, it's good to have the building, but do you have, because usually the taste of the pudding is in the eating. So the actual functioning of that facility is in resourcing it. So yes, you may have this grand plan, but what is the long-term plan of making sure that it works? But we have facilities that work, dispensaries, health centers that are just shells or are really offering sub-optimum services because they are not resourced. So I would start by making sure that they are resourced, one, by human resource. Most of the time, there's somebody who's been posted there to work there. There's somebody on the payroll for it. So make sure that those people are actually offering services. But then again, the second bit is to make sure that you give them what they need to offer. So if I need gauzes, if I need a sterilizer, if I need medicines, vaccines, make sure that they're there. And then 3 is now to sensitize. And I think this is the conversation going round that over the last 10 years, people have learned that my voice is actually needed for the county governments, for the national government to work. So do a public participation conversation, involve the public so that they know you should go to health facility X. And if you want a vaccination, if you want your wound dressed, if you want first aid, they should be able to offer it. If they are not offering it, let us know so that you have done your part and you let the citizens do their second part. So you make sure you devolve them, or you make sure the basic or the primary healthcare functions are actually working. And this is just at dispensary, community level, and your health centers, because these are in almost every corner, including Nairobi, a very big city, but every corner has a health center. And this applies also to, the arid, the far-flung areas. But then now in the far-flung areas, you need to rethink. If people are going to move in search of pasture somewhere else, then you need to work within their cycles. And I think what I've seen is that when you offer solutions that work, or that make sense considering the socio-cultural uniqueness of people, then they become longer lasting solutions. So to think it like that. But I would think no need to reinvent the wheel. Make sure that whatever you already have is working.
Is already working.
Then we look at the second tier, because now this will be on the basic healthcare, preventive healthcare bits. Now you look at the second tier, which is the curative, which I think is where we most of the time put a lot of effort, because you want to get a surgery, fair enough. You want cancer treatment, fair enough. But that would be at the second level. Because remember, if you pick things early, then it means you have lesser demand on the curative side of the healthcare. So I think for me, over the next 5 years, I would hope that people look at, can we get the basics right first? Can we make sure the bottom of the pyramid in terms of healthcare is actually sorted out first? And then now work on this other, curative or specialized kind of healthcare.
This is the Situation Room, the only way to start your day.
Talking about the new administrations at the county and national level and focus on healthcare. And she says two things. One, focus on how you are going to finance the health system. And number two, focus on how you're going to manage the human resource. On the management of human resource, that conversation, do you expect to see it heading anywhere in terms of returning human resource to a centralized management system?
Realistically, I don't. Maybe later in the future, but in the next 5-10 years, I honestly do not see that happening, because the counties are now 10 years into devolution. Some have worked quite well. I think Makueni has been the star when you talk about
poster child.
Poster child, yes. When you talk about making healthcare work, I'm sure probably they have other issues, but when we look overall at what they've been able to do and what they've been able to achieve for its people and its workers, I think it's been the poster child. So I think it would be a much a deeper conversation between the healthcare workforce and the county leadership and the national government leadership. But from what I see, from where I think a lot we say from where I sit. So from where I sit, I don't see that being something that can happen in the next 5 or 10 years. Maybe later on when people have seen what is happening. Because remember, this is a whole political conversation. It may make sense. For example, if you think about, say, the specialized people that we have, say the neurosurgeons, say the maxillofacial surgeons, for example, those really few people.
They're called what, super what?
They're not,
they're not in the level of
not
super.
yet super.
Are super specialists?
Not yet
really.
Okay, but there are those from there who have super.
It's not a super.
No. So after you do maxillofacial surgery, you can super specialize.
Okay.
After you do neurosurgery, you can super specialize. But now we're looking at them as, because there are few. It takes 6 years, for example, for you to train a neurosurgeon. So when you think about the time it takes, the number that there are there, then for me it would then make sense to have a conversation. Should you have a certain cadre or specialist under a national
At
pool,
a national, okay.
so that you, from a national perspective, you're able to see this is the area where we need these people most, this is the area where we need these people most, instead of having them converged in one place, yet there are other places that are, deficient or do not have
So
specialists.
they can also be assigned in a cluster of counties.
Yes,
so
yes,
this is
exactly.
a neurosurgeon
Yes.
serving this
3-4
particular regional
counties.
block.
Exactly, something
Okay.
like that. So there may be a conversation for that. But if you're looking at lower level cadres, then probably maybe they can be hired from a county level perspective. So yes, there may be justification for that, but considering it's a political conversation more than
Practical
a
solution.
practical technical solution building, I think that needs a lot of lobbying, a lot of discussions from the associations, the unions, with the governments that are there. So, and that, as we know in Kenya, that's like moving an elephant. It takes time. And what we are talking about on the health financing, and what I was telling you, I need more money in my pocket. When I think about the Harambes you contribute to,
Yeah.
when you think about even yourself, you pay for your own private health insurance. You have NHIF being deducted every month because you're on formal employment. If you think about it, if I only needed to pay NHIF, whatever amount it is, 500 shillings, and I know if I walk into this health facility, I'll get all the services I need. It means if I was making another 3,000 shillings per month on medical related expenses, that's money in my pocket.
Yeah.
At the end of the year, in the long run, I have saved a lot more money. So it's not just about looking at a way of financing, but it's also looking at alleviating the suffering that we go through from contributing to healthcare. The second one is on, if we are well financed, then it means I can seek healthcare services when I need, at the time I need. One of my colleagues was just telling me that surgical services, for example, are not easily accessed by several Kenyans. So say cancer, you need a surgeon to remove something. This surgeon is not available. You have to wait 1 month for it. What does it do? By the time you're going, probably now surgery is not even going to help you. You
Yep.
need even chemotherapy, radiotherapy. It becomes even costly, and it has a strain now on the healthcare service provision. So we have to think about it on those two tiers. One, providing healthcare services, but most importantly, making life more bearable for me as an individual living in this country. Yeah.
When you talk about providing healthcare, that conversation, perhaps if we tilted it a little bit into something that we understand and we can manage, appropriate and affordable healthcare. Because the conversation about the preventative aspects of healthcare tends to be just that, a conversation, and then it's brief and then it comes to an end. And yet, research science has proven how it is that approach actually reduces significantly hospital, not just healthcare, hospital and healthcare attendance by people. Now, you as a healthcare provider and a healthcare practitioner, really, how does one ensure that we tilt that conversation to something that is actually doable? The Nairobi Metropolitan Services and the way they've gone about it, I know they have invested heavily in what you call community units. Okay? Now, those units, Dr. Umaluga was here and explained to us, community-based, that particular configuration is what helps them understand when if you talk about health surveillance and you talk about details that you want, because you're talking about locals working within the communities in which they live. They are not only able to provide healthcare based on, should we say, knowledge that has been provided for them, but they're also able to retrieve and get knowledge on what it is that needs to be done simply because of that particular focus. Mercy, why is it that this conversation never goes beyond just that, a conversation, and yet it's something that can be done?
I go back to where I started. Health, the benefits of investing in health are intangible. You'll only say you have reduced disease by so much. You have X number of people that are healthier, more productive. It's not like you've done an expressway we can see, and it's immediate within a year or two. But for health, the benefits are intangible and they take long. So one, for me, is for our leadership to see it as that. I mean, you don't expect that you'll invest in health and you'll get something immediate in return. It is a healthier population, a more productive population that will be in place. The second one is when you talk about preventive, promotive health, and I've seen this in I think it was Elgeyo Marakwet. You sometimes need people in motorbikes to go into the community because, I mean, it's vast, or the terrain is challenging, so you have to put this person on a motorbike to go. If you don't fuel that motorbike, what happens? The person will not move because, again, you do not expect that we have employed you and we do not give you the tools and the resources to work, which is what I was talking about. You have public health officers, and people in Kenya are actually very well trained. We've seen our policies, they're very well done,
Yes.
but the implementation is the challenge. So if you're really serious about primary health care, if you hire your primary health care practitioners and public health officers, environmental health officers, all of those, it is not just enough to say I have X number of public health officers or X number of doctors. Give them the tools to work so that you can demand and know. So what is the community saying? What do we need to do with the community? But if they're coming to the office to go through newspapers, fold and go back home, you're doing nothing.
Cascade the discussion to something more basic and very community-centric. Community health workers. Okay? My constant reference is to the ICCM approach, the research that went on to it, integrated community health management. Just making sure that people within the community not only understand the things that predominantly ail them, but understand that the intervention doesn't require you to make a long, torturous, expensive journey to a health facility. It's like when you talk to, say, county health officials, they know it because they're trained health personnel, but there's a resistance to actually implementing it. How do you explain, for instance, the number of health workers or the number of public health health workers, how many you have in a community? The numbers alone will tell you how seriously that particular county, for instance, takes this matter.
Yeah.
And when you talk about the resourcing that you're referring to, it will also tell you when counties and health officials within those counties talk about the predominant discussion is about partners who are supposed to help them provide healthcare services. The question always arises, so then what is your job exactly? And then what happens when these partners pull out and they're no longer there? What happens with these people and the health provision? You have money, you have a budget. Fundamental question, what do you do with it?
Actually, you raise an important point, and I think it's a current conversation about donor funding. Donors are slowly, letting us fly on our own, if I may call it that. But you find, and I think we saw this with the blood issue, that when PEPFAR funding came to an end, which we knew it would after 15 years, all of a sudden there was a crisis because we didn't have funds. But for 15 years, we knew that this funding is not infinite. It will come to an end. We didn't do a plan to make sure that we are able to sustain the programs that have been there. And that goes to what you're saying, the seriousness of how we take some things. And one of the things that people are proposing is, as a country, we should be able to, on a dashboard, know this and these are the things that ail us. These and these are the things that we need funding for, so that if a donor comes, it's not their programs or their interests that we are looking at, but you're telling them, this is our dashboard. Choose where to fit in and where to support us, so that we are progressive as opposed to really relying on the issue of donor funding. And the other thing about funding in health sector, and still a conversation that the next government should look at, should the funds going to the health sector be ring-fenced? Because if all the funds go to the county pot and say Governor 049, and health is not really an important thing, but I think building roads and market stalls is important. I will take the funds from health and put it in this other area.
Yeah.
What happens to the health sector? And we said it's resource intensive. It needs the consumables. It needs the personnel. Some of this personnel, because they are few, you need them on a short contracts or locum basis or a casual basis. So if you do not have the funds to take them back to it, what happens then if my priorities are wrong? So is it about time we looked at the financing to the health sector and ring fence so that all the funds that come into healthcare, if we have said that these funds are going to public health, that they actually go to public health and we demand results from it? Because, I mean, governors say they are the CEOs of the counties. So if I'm putting in money as a CEO to this public health officer, I've made sure he has a motorbike, I should be able to get a return on that funding, on that investment,
Indeed.
and get the response back on what are the people saying, what is the need of the people, where can we now put in more money?
Yeah.
I think that's how we need to look at it.
Should you still look at, because I think this conversation has been back and forth, should then health go back to the national government? Should it really be devolved? And I know that you've often given arguments as to we've seen improvements because of devolution, and that health then being devolved has actually made sense. But then, following kind of like the same example that you've given, should it be one big pot? And we know that this is the agenda across board, and then everybody then gets their share in order to fulfill that. That's one option. Because now we're also talking about, new governments coming in, or rather new individuals behind existing governments at the county level. I think everybody who said they wanted to be governor had a health plan. Everybody has their something.
Even the presidential candidates.
Exactly.
Everyone.
Is that the way to go? Or should we say, can we fix what exists and then move forward? The cry from Yegon here sounds funny, but many people are in that place where they say, can this thing go back to the national government? We are tired of being under Fuliza county governments where everybody has their own agenda. It's political, and we can't run away from that. So what really then would be the solution to get this caboose moving?
Schedule 4 of the Constitution devolved these functions, and the Ministry of Health has very clear mandate on policy, and it should guide the policy conversation, the policy development on health for the entire country, so that if our policy as is now is to make sure we have universal health coverage, which means quality healthcare, affordable healthcare, and access to that healthcare, all the 47 counties should be able to adopt that and implement. So it's not that they work in cross purposes. The Ministry of Health is providing the leadership in what the health agenda of the country is. The county governments pick up that policy and customize it according to their needs in that particular region and the uniqueness of that region. For example, we're talking about universal health. If my county has high burden of infectious disease, then it means my priority would be to make sure that in this UHC agenda, I have worked on infectious disease. If my issue is on maternal health, I make sure in this UHC agenda that the maternal health access and quality healthcare and affordability. I have worked on it as a county government. So they should be working together in that counties implement or contribute to the policies and make sure that that policy is implemented to the letter. But what we see is everyone now, I am a boss of county zero something. And so I want to do it my way, or if I do not support the government of the day, I do things my own way. At the end of the day, everyone here is serving a Kenyan. All of us are Kenyans. And it should be that if today I'm working in Nairobi, if tomorrow I'm working in Samburu, I should be able to have the same access to care that I have in Nairobi, or if I'm going to Kisumu, it should be the same. So I think it's about time. It's good, yes, and I've always said this. I think we have come a long way, that the campaigns are based on health. There's a time nobody talked about health and what they are going to do on health. But now we're actually looking at what is your manifesto on health? What are you going to do on health? We've come a long way. But now we need to take it a notch higher and make sure that if you said you're going to provide water so that we reduce diarrheal diseases in this area, we hold your feet to the fire if you do not do that. So the conversation, I think we have moved a notch higher. So now it's about implementing and making sure that the Ministry of Health, which still has an part of the conversation, Ministry of Health really has a big budget on health.
I think the Ministry of Health should drop a lot of the things that it's doing. The Ministry of Health should just be a data office, should be a library for the country. Develop a policy once. You don't develop a policy twice a year. It's a once. There's a policy on this, move. There are standards. You've developed standards on this, move. The rest you're just doing is collecting data. Why should the Ministry of Health be at the center of implementation of programs at every stage? I think this is what causes a lot of the issues that we're having.
It's essentially a reluctance to actually move away from that centralized system.
Yes.
Where you're talking about roles that have been devolved, but the actual...
still holding on to it.
Yes, not just holding on to, the conversation is the money that is actually required for devolution is still sitting at Afia House. Now, so surely that definitely, most clearly is not devolution.
Let the counties, let the Council of Governors or IGRTC and whoever sit and determine we want to collectively procure equipment. Not the Ministry of Health saying we can procure equipment
Even
for you.
For you.
No, let them decide and let them come together and do it. If it's a regional block that decides this is how we're going to do it, we're going to approach, we're going to
Whoever.
float a tender, then we'll get equipment and we'll be paying back this way. Collectively, we've agreed. Let them do it. The Ministry of Health is just basically the stumbling block to our
Let the
attainment.
Treasury underwrite it so that it's done.
Yes.
The thinking behind MES makes sense. However, the implementation was completely off the charts. Okay, that's as polite as I can be on this particular matter.
The Senate agreed with you. The Senate committee agreed with you. Yeah, that
It was a criminal enterprise.
Yes.
So they called it.
Yes. Yeah. So the ministry, and actually many ministries, if you think about it, that are
Agriculture
devolved,
as well.
need to let go of some of the, especially on primary health, public health. That needs to actually go to the level of the people on the ground. Deal with the level 6 because when we need highly specialized care, we'll come to you. Policy because we understand that you have an overall view of what is happening in the country. The training that they've been made or that is they should be able to do. Let them do that. But I think the actual work for me needs to go to the counties. Counties need to make sure that they work and deliver.
You know what Eric is suggesting? The role that probably the ministry should actually provide. If you're talking about specialized personnel, if you're talking about health economists, you're talking about costing experts, the ministry has them. They're not looking for them. They have them.
Many.
These are the people whose services should be farmed out to the counties.
Yeah.
If they have a shortage, if they have a depletion, if there's a gap, this is where the ministry should fill in. But not that when you have a gap, then you have to keep coming back to the ministry.
You're all the way up to the top.
Sure.
In fact, even those guys should be under Ministry of Devolution, like everybody else.
Yes.
Devolution. So with the Council of Governors, we need expertise on health. You guys come attend this meeting, help us to shape our thinking. Afia House, funga.
You can't close it entirely.
Actually,
Close
no.
it.
An extreme view like that is often necessary for you to actually
Get your
understand.
caboose into thinking.
Exactly, because we
These
don't want
guys are not training. They have developed the training standards. Training is being implemented by
accounting.
education.
Yes.
By universities. Universities are under education ministry. Why do we need guys sitting in that office to do it?
No, the training is to sponsor medics going for further studies.
Yes.
So that
See, that
they-
can be done at the council level.
Well, you've seen that conversation where counties are asking, and it usually maybe it's a legit question. They've put I'm on a salary, but I'm out to study in Kenyatta, and I'm still drawing the salary from the county.
Yeah.
And there's a gap.
Yeah.
But then there've been solutions
is what I'm
proposed
saying.
for
Go to
that, where
go to
you
the council.
train locally through the fellowships. So if you want surgeons, there's a COSEXA training. Let them work in that facility, and then they'll just do an exam after a certain period of time, meeting
Yeah.
certain expectations,
Yeah.
so that you do not have to physically move me from Nyamira, for example, to come to Kenyatta
What you
for
need
training.
is a committee for that. Ministry. Anyway, Mercy, thank you very much for joining us. Next week, Friday, let's talk about that. Do we need a Ministry of Health going forward?
Let's throw the Ministry of Agriculture into it while we are at it, yes.
And fisheries.
And fisheries and all. Anyway, we wish you a lovely weekend, and thank you very much for tuning in to Kenya's biggest conversation this week.
This is the Situation Room, the only way to start your day.